for liver disease. Obviously, this is not exhaustive. We cannot really resume a lot of the intricacies of liver disease management within an hour, but I hope that it's going to at least be a good introduction. I'm based in Vancouver, and I'm VCH staff. So we acknowledge that, or I can acknowledge that I work in the traditional and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations. I don't have any disclosures of or conflicts of interest associated to this presentation, and these are really the objectives of the talk today, is to talk a bit more about chronic liver disorders, particularly interest in what I would say are the two main liver disorders that we see. Discuss some things that are specific to each condition and maybe that are applicable to most of them. I will not be talking so much about acute liver injury or acute hepatitis, as this is definitely a very different topic altogether. This is the outline of the presentation. The two common liver diseases that I decided to discuss a bit more about today is what we call steatotic liver disease, or what we may know more as fatty liver disease, and alcohol-related liver disease, as these are the two more prevalent liver conditions that we see. We're going to have a little bit of a discussion on advanced liver disease in general and the patient that with cirrhosis, and how to manage initially a patient who's presenting with abnormal liver enzymes. So if we start with the first part, we can quickly divide the patients that are presenting with liver enzyme elevation into major categories. Based on the type of liver enzyme that is abnormal. So as you may know, the four main liver enzymes that we measure, the AST and ALT, and then the gamma GT and alkaline phosphatase. We refer to primarily cholestatic liver disorders, to conditions that will affect more the bile ducts of the liver, and hepatocytic disorders, those that affect more the main tissue of the liver. And there is obviously sometimes an overlap of what liver enzymes are elevated. So that's why we say it like that. Primarily, these liver enzymes will be increased with these conditions, and primarily the cholestatic liver diseases, or sorry, the cholestatic liver enzymes will be elevated in these conditions. The idea is just to know or have a better knowledge that when we have a certain type of elevation, we should be considering some other types of disease over others. When should we test for liver enzymes? It's a good question. There is no strict guideline that it should be part of an assessment of the patient that is otherwise feeling well, or sort of like the routine medical examination. Also, patients with liver disease, at least initially, either will rarely have any symptoms, or the symptoms that they will have will be really non-specific, so not something that we will just see with liver disease. What are some of those non-specific symptoms? It could be things like, weight loss. It could be fatigue, low energy, and rarely we will see the symptoms of, for example, jaundice presenting as the first manifestation that there could be something wrong. Now, sometimes some physicians will prescribe liver enzymes during their general checkups, and there's some anomalies that can be picked up there. We recommend to sometimes think about testing for liver enzymes in potential patients from high-risk groups. So based on the year that they were born, so birth cohorts, especially when we're thinking about screening for hepatitis C, birth or country of origin, because it can also be associated with certain types of liver disease. When there is a presence of what we call a metabolic syndrome, so some people who have diabetes, hypertension, high cholesterol levels, or maybe also in the presence of someone who acknowledges some high degree of alcohol consumption. What I recommend sometimes in people or after one blood test showing an elevation of the liver enzymes. The most important thing probably at the beginning is to retest because it will give an idea of the trajectory of those enzymes, but also because a lot of times the elevation could be due to a very mild transient event. For example, they were done after a cold episode, and that will elevate the liver enzymes. It could be done after taking some medication or after taking something, some natural product, and the elevation may not necessarily be persistent. So it's a good idea to just start with retesting and see if this anomaly is persistent. I often have referrals for patients with high bilirubin levels, but not all high bilirubin levels are because of liver disease. It can be due to something else that is more in the domain of the hematologist and not the hepatologist. And in that case, it's important to have all the information with values of the direct and indirect bilirubin. It's also good to have the AST values as part of the panel as well. It's not always included in standard panels to have the value of the AST, and it can be helpful. The blood test that I put there in select is what I would say the minimal testing that can be done at the primary care level to start picking up potential hints as to what could be going on. Not that we will not necessarily do it if the patient is referred directly to the hepatologist after a liver enzyme elevation, but it does already provide some screening that will make us, to some extent, prioritize or triage some of those referrals. An important one to think of because some people ignore, and it's an easy one, is if we have someone with predominant elevation of the cholestatic liver enzyme, so that gamma GT and alkaline phosphatase, to test for these antimitochondrial antibodies, as there is a condition that is very easy to diagnose when we think of it, which is primary biliary cholangitis, and that can be quite common in different areas of the country. Having an ultrasound of the liver also very helpful to see if there are features that are suggestive of more advanced liver disease or of the presence of fat in the liver or some other anomalies of the bile ducts. A lot of physicians sometimes refer patients with high ferritin levels, and they do this mutation testing the HFE for hemochromatosis. I'm careful with that because it all depends on the population that you're dealing with, but it's a mutation that is extremely rare in patients that do not have a European ancestry. And as such, if it ends up being done in older people, it could be leading to a lot of waste of resources then. So probably something that should be left to more at the specialist level to see if it's relevant to test for this mutation. One of the important things that we assess when we are seeing the patient in our office and is how much is this disease a problem? We can have elevation of the liver enzymes, and sometimes if we understand what is causing it, we can predict what could be the trajectory of the disease over time, or whether or not it is something that to be concerned at this moment or not. Sometimes having abnormal liver enzymes, if it's something that is under good control, may not be a big problem because of the capacity of the liver to rejuvenate itself and counterbalance that inflammation. But one of the things that we do on a general basis is to try to have an idea of how much scarring the liver may have developed. And for that, we have tests that we can do based on blood results, tests that can be done using some form of imaging technique, and obviously at the end, the liver biopsy. So what are these blood tests? The blood tests can be separated in blood tests that are available openly. So anyone can calculate them if they put in the values that are asked, and others that actually have a sort of like a patent or a copyright where we don't know exactly what is the calculation. We know what is sort of included in the test, but we don't know what is the mathematical calculation that estimates the risk. Yeah? So we don't necessarily use a lot of these because they have more cost associated with it, but there is some data out there of their potential validity. Most of the time we use things that are fairly simple. These scores are really calculated with results that are easily available on the blood test that we check, and where there are a lot of online calculators that help us to assess this. Now, this table is a little bit crowded, but I don't want to give a lot of details of this. This is just to provide a little bit of what are, how we have the mathematical calculation that we can use, and in some of them we don't know what is the mathematical calculation and what are the elements of the blood test that are requested for each test. It's just to give an idea of these various tests that are available. There are limitations for the blood test, and these are the types of limitations. They are influenced by age extremes, so less reliable in very young people and very old people. If you have had some form of surgery to remove the spleen, it will also impact on the platelet count. If there is active alcohol use at the time of the test performance, it can also have an impact. The degree and the severity of inflammation can also move the test erroneously in either direction. And there are other medical conditions that will have an impact on how reliable the test should be. So they're good, but they're not perfect. So a lot of times then what we're asked to do at our office is to do something that we call elastography. So elastography can be measured in different ways. We have a transient elastography that is better known as the FibroScan. We have the shear wave elastography, which is measured by ultrasound. And we also have the techniques such as elastography measurement by MRI that can be quite accurate. But even those techniques of elastography can be limited by some characteristics, such as the presence of obesity, the type of inflammation, or what we call cholestasis. So if it's more the cholestatic liver enzymes or the bile duct-related liver enzymes that are high. If there is a lot of pressure in the liver, if the liver has difficulty pumping blood out of it, it can increase the values. If there is a lot of inflammation, or even if you get your test done after eating. So there is usually a fasting state that is requested by a few hours before we do these elastography tests. When should we think about referring to a liver specialist? Basically, we have a persistently unexplained elevation of the liver enzymes, or if we have a liver disease that has been identified that requires more specific follow-up. Generally speaking, the cholestatic disorders should have an opinion by a hepatologist because of these conditions are a little bit more, I will say, difficult to differentiate than others. If we have people with high elevation of the liver enzymes, if we have someone that should perform some of these non-invasive blood tests and they said, oh, this person is at risk of having high fibrosis, then it's good to have a confirmation test with us. If there's already enlargement of either the spleen or the liver in an ultrasound, for example, if there are more manifestations of advanced liver disease, and if there is a possible chronic liver disease that, as I said, requires a long-term follow-up. A lot of times we have patients that are refer because they had an ultrasound for some reason. The ultrasound showed that there was some fat, but the liver enzymes are actually completely normal. And in that case, it's probably not necessary to refer to a liver specialist at that moment, but mainly just to keep an eye on that patient with monitoring of the blood test and also reassessment with these techniques of evaluation of inflammation or fibrosis on an annual basis to monitor what is the trajectory of the patient is. And when we start seeing maybe that there are some variations that go back to this high or indeterminate blood test assessment for fibrosis, then it could be a good idea to refer to a liver specialist. So we have developed guidelines by different professional societies that use especially the FIB-4 score. So the FIB-4 score is based on the age of the patient, their AST and ALT value, and their platelet value. So what is said with these guidelines is that if your FIB-4 is on a low range, it doesn't necessarily require a hepatologist assessment, but probably just a monitoring and annual reassessment of that FIB-4. If we have indeterminate results or advanced fibrosis, that is when it would be a good idea to refer for a specialist opinion so that we can have a confirmation test and then guide our future management based on the result of that confirmation test. Oh, I thought that I moved them from the end. I think that I have them at the end. So I'll probably just move away from this at this moment. Yeah, I think I have them at the end. So if we go back to now these common liver disorders and starting by steatotic liver disease, which we probably know better as, fatty liver disease. So the terminology first of all, the terminology of the name of the disease has changed. We used to call it like non-alcoholic fatty liver disease, but there were some problems that were debated and identified about that name. So eventually it was changed to what we call steatotic liver disease. Now, when we have this steatotic liver disease, steatosis basically is the medical term for fat. We try to get an assessment if the patient has a history of alcohol use that is significant, or if the patient has these what we call metabolic risk factors. So the presence of diabetes, the presence of high cholesterol, obesity, increased abdominal girth. So what we call a metabolic syndrome. If we have a metabolic syndrome, this steatotic liver disease will be called MASH. MASH or MASLD. MASLD is if there is no inflammation, MASH if there is inflammation. If there is some history of alcohol use, we're going to call it MET, so metabolic, but also ALD, meaning that there is a combination of both alcohol-related liver disease and also a metabolic disease. If it's a pure alcohol-related liver disease, and we're just going to call it alcohol-related liver disease. And then there are other conditions that are outside of this, which are more rare conditions and not necessarily something that we find on a regular basis. So the terminology has evolved to better characterize the different types of presentation of someone who will have, quote unquote, fatty liver disease. So these are those metabolic risk factors that I was talking about, the presence of obesity based on BMI, which is not always perfect on everyone, the waist circumference, the presence of type 2 diabetes or diabetes in general, the triglyceride levels and the cholesterol levels in the blood, and also the presence of high blood pressure. Who should we screen for the possibility of steatotic liver disease? At this time, the professional guidelines do not recommend a screening of the general population. But they should be considered in patients that have some of those risk factors. So patients with diabetes, other metabolic risk factors, obviously patients that have elevated liver enzymes, and patients that have a lot of these comorbid risk factors. And on top of that, we find that they also have on ultrasound the presence of fat. When we screen or when we follow these patients that we have a high probability of steatotic liver disease, we will follow similar recommendations to what I showed you before based on their FIB-4 score. Their FIB-4 score can be used to see who can continue to be just monitored by their primary care provider, or who probably would need a second assessment by a specialist and to get a confirmation test, and based on the test, decide as to how often, how frequent those encounters with the specialist should be. How do we manage steatotic liver disease? We try to identify the risk factors and try to optimize them. The first thing is to try to complete some investigations or gather more information about several parameters of the patient's physiognomy, their potential presence of metabolic risk factors, and consider a screening for sleep apnea as well in patients that have risk factors. In some people, probably also screen or assess for the possibility of polycystic ovarian syndrome, which is often associated with steatotic liver disease. When we go to this table, what I want us to focus is on some of these lines here. So the first one is that when we see weight loss goals, because it is what we will recommend the patients at first, is let's try to see about strategies for weight loss. What I tell my patients is that even though we are using the weight or the weight on the scale as a surrogate, sort of like an approximation of the work that we're doing, I also ask them not to focus so much on the result on the scale if they are actually following the recommendations in terms of dietary changes and maybe physical activity, because we can have positive signs internally or positive metabolic activity happening internally, even if at the end of the day, the weight on the scale doesn't really change that much. Okay? As a general rule, how much weight we target to lose for a patient will depend on how severe things are. So if it's just a little bit of steatosis without so much inflammation, 5% of weight loss could be sufficient as a target. And if there is more inflammation, then we ask maybe to try to see a little bit more. And then if there is fibrosis, maybe try to aim for a 10% weight loss to attempt some fibrosis reduction. What type of dietary modification we said or to follow is we try to minimize processed foods, sugars, refined sugars as well, and increase the amount of protein in the diet. Physical activity that is recommended is 30 minutes, 3 to 5 times a week of some cardiovascular activity that is moderately intensive. And finally, we recommend to decrease alcohol intake or maybe even avoid it, so that it is not a contributor as well to development of scarring in the future either. There are no really any drugs right now that are made for reversal of fibrosis or directly affecting fatty liver disease. But there are medications that are approved for other indications that could benefit patients who have steatotic liver disease. Use of statins, so for cholesterol, is also strongly considered in that population, even among those that have some more advanced liver disease. Vitamin E is probably the easy one, but vitamin E, it's important that we go and ask for the natural form of the vitamin E because that's where the evidence came from. A dose of 800 units daily. It does reduce inflammation, but without so much effect on fibrosis, so it will not change fibrosis. There are some risks with this medication, possibly cardiovascular risk, increased risk of prostate cancer, and maybe also of stroke. So in people that are at risk, maybe something that we avoid, but otherwise in maybe younger population, it's something that could be considered. Pioglitazone is an older form of diabetic medication that had some evidence as well in the management of fatty liver disease, but we don't use it so much anymore because of the risk of weight gain and also congestive heart failure. So it has fallen a little bit out of favor for many years now, although it is attempting to make a comeback. There are new medications that are now used for diabetes, mainly these GLP-1 receptor agonists. People are very familiar with semaglutide, which is the famous Ozempic. But there are medications of the same form that can improve the amount of fat, the amount of inflammation, can have beneficial gains on weight loss with some side effects as well that we encounter. There are other medications as well, like the SLG2 inhibitors that also have had some good effects on fatty liver disease. Medications like obeticholic acid have not really worked that well, and due to concerns of side effects, they withdrew their MASH program for this medication. There is a new medication that is at this moment not necessarily available in Canada, at least not on a commercial basis, which could be eventually associated with weight loss, but also improvement of steatohepatitis. So my recommendation is that these choices of pharmacological agents are really dependent on many factors that are specific criteria of the patient, and also the reimbursement programs and availability in different areas of the country. Now, if we move to alcohol-related liver disease, the most important thing to keep in mind is that the management or the treatment of alcohol-related liver disease goes hand in hand with the treatment of the alcohol use disorder. So if we only think of one without taking care of the other, at the end of the day, we're not going to be so successful. It is important to screen for potential alcohol use disorder our patients, especially those who present for abnormal liver enzymes, patients also with obesity because of that increased risk of that MET ALD. And there are quick questions that we can ask in the office as a screening test, which is, for example, how many times in the last year have you had more than 5 drinks or 4 drinks in a day? And anything that is more than one should probably raise a second discussion. And there are other tests like the Audit C or the shorter version, that is the shorter version of the Audit, which are questionnaires that we can find online, we can find in our med calculators that can provide an idea of how problematic the alcohol use of that individual is. Now, you've probably heard recently, a few years ago, about the Canadian guideline on alcohol and how strict it looked compared to maybe other guidelines as to how much we quote unquote were allowed to drink. People had a misinterpretation exactly of what the message was, and also just keep in mind that this guideline for alcohol focus mainly on the risk of alcohol on non-liver related outcomes. It was criticized even within the profession, especially, for example, the cardiology group was very against it because they have in their medical literature a lot of support for drinking wine and heart protection. So they were very against. They were strongly against, at least some specialists against these guidelines. Now, the message of the Canadian guidelines was that if you drink 2 or less units of alcohol a day, your risk of any health-related complications is probably negligible. If you drink more than that, well, it is a higher risk. So the more you drink, the higher the risk of any health-related issue. So sometimes when I bring this discussion with my patients, I tell them, or I do this driving analogy with them, which is basically, how fast you can go with your car on the street will probably depend on some factors. It will depend on, are we on a highway, on a clear day, straight line, no one ahead of us, or are we on a school zone? Are we driving a sports car, or are we driving a Lada or any car that probably is not fit to go through those speeds? So if you have some conditions that put you at risk of getting off road, then maybe your speed should not necessarily be 200 an hour. Maybe you should limit to 30 an hour. Okay? If you're not driving on a highway, but you're driving on the school zone, maybe also then you should keep your speed low. So if you have risk factors for liver disease, maybe you should not drink that much. And maybe if your only problem or your only issue is cardiovascular disease, maybe then having your glass of wine every day, as the cardiologist would say, maybe it is fine. But at the end of the day, everything should be dependent on individual risk factors. There are tests sometimes that we can ask, or biomarkers that we can test in blood or in urine to assess if someone is drinking maybe more than what they are really reporting, or maybe they are reporting that they're not drinking at all, and we can use those biomarkers to test. The professional societies encourage us to use these biomarkers when available, but not as a way to really catch the patient in the act, but more to say, hey, this is a tool to provoke a discussion, to open up on a discussion if we find it to be positive. There are different tests that can be used based on urine or serum tests who have a different degree of sensitivity and how long they detect the alcohol exposure. We can still, in this population, use the FIB-4 score that I have shown before to screen the patients that may require further evaluation. But we could also consider in patients that are at high risk of disease because they have other risk factors, such as the steatotic liver disease, for example, or maybe other liver diseases, such as hepatitis B that is chronic, or chronic hepatitis C infection that is not untreated or even treated, to maybe assess better. People maybe that are of an advanced age who are at higher risk of having developed scarring over time, or if we have any features that the liver is sick on ultrasound, or even in the blood work that is not getting better even after stopping the alcohol. We recommend healthcare providers to be familiar with the pharmacotherapy or the potential anti-craving agents, because they can be of good use in the management of the alcohol use disorder component. In BC, we have a collaborative prescriber agreement form that can be used to try to get access to naltrexone and acamprosate. There is a benefit from referral to psychological interventions as well in the future as co-management for alcohol use disorder as well. These are the main medications that are that have an indication for alcohol use disorder treatment for as anti-craving agents. They all have their benefits, their side effects, or their limitations. So they have to be individualized to the case that we have in front of us. Now, moving to more the chapter of advanced liver disease. There are liver conditions that even when found at an advanced level can improve if the underlying liver injury is controlled or removed. So this is very classic of treatment of hepatitis C and hepatitis B and alcohol with abstinence. Or maybe to some extent, patients with all these autoimmune conditions that are responding very well to the treatment. What we do in general with the patients is that we just monitor for progression, either of the biochemical results, the anomalies of the results, the features of what we call portal hypertension, or the development of liver cancer. So this is where probably maybe a little bit more difficult to understand in non-medical trained people. But when we have a patient who has cirrhosis, at the beginning, we can refer this as a compensated cirrhosis. So even though the liver has cirrhosis, it still works quite well, and they don't have a lot of high blood pressure within the liver system. But as the disease continues to progress, then that's when we can call that there is decompensation and then further decompensation based on the appearance of those features of progression. So the ascites, which is the accumulation of fluid in the belly, the bleeding of varices, the development of that confusion that we call hepatic encephalopathy, all of that are signs of decompensation of the liver disease, or that we're moving from phase to phase. For us hepatologists, we can get a lot of information when we are assessing the patient with advanced disease based on their FibroScan scores, based on information that we have on ultrasound, based on information that we have on endoscopies that we do. And all of that is going to guide us to decide how often we need to repeat the test, how often we need to do blood work investigations and monitoring, the frequency of the ultrasounds. All of that is going to be guided by that information. So I would say that anyone that has advanced chronic liver disease, due to the subtleties of the evaluation, should be managed by a hepatologist or a gastroenterologist or an internal medicine doctor who has a training in liver disease. What we measure or what we try to monitor, we try to take some vital signs. Sometimes, I would say that the patients with advanced liver disease are not the best patients to be monitored by telehealth or telephone conversations, especially when they're more advanced. It's people that it's worthwhile to check the vital signs, check their appearance, evaluate with physical exam how they're doing. We do the abdominal ultrasound to screen for liver cancer every 6 months with a blood test that is called the alpha-fetoprotein levels. Depending on how severe their liver disease is, we can monitor the blood work once to every 6 months. It should be at least every 6 months if stable, but anyone who is a little bit more active should have the blood work done maybe more frequently, every 3 months or every 1 month, if there is a very advanced disease. We are doing less and less of endoscopic screening for varices at the beginning. We use more our techniques of FibroScan to decide who needs one, but there's still a role to check for varices with the gastroscopy in some. How do we manage, or what are our general recommendations? Limit salt intake to 2 grams of sodium, especially in those that have some swelling going on. In patients with advanced liver disease, alcohol intake should really be prescribed. We should really aim for complete abstinence, and that is really regardless of what is the cause of the liver disease. Something that is out there is maybe the avoidance of raw seafood or undercooked fish in patients with cirrhosis, Why? Because there is sometimes a bacteria that can be found in seafood and fish called Vibrio. And Vibrio, for some reason, in patients that have cirrhosis and advanced cirrhosis, can actually be more um, severe than if someone without liver disease will catch it. We should really aim for a high intake of proteins, at least 1 gram per kilo per day. And if there is more progression of the liver disease, even try to increase that to 1.5 grams per kilo per day. Avoid prolonged fasting because prolonged fasting can increase the risk of encephalopathy episodes when you have advanced liver disease as well. As I said before, there is no medication that exists right now that has the approval to reverse fibrosis. So once there is that fibrosis, there's nothing that we can do to take it back. Although it is possible, as I said, that we can see rejuvenation if the underlying cause of liver disease is gone. But we will never go back to a normal looking liver necessarily. We treat the ascites with water pills that we use in a ratio of 40 to 100 or 4 to 10, depending on the unit. And we adjust the dose based on the control of the fluid retention. If someone starts developing that confusion that we call hepatic encephalopathy, we start prescribing lactulose. I personally avoid more than 90 cc's per day because I feel that at that time, beyond that dose, it gives more of a lot of cramps and bloating and not necessarily help so much with the encephalopathy. So in someone who is refractory to lactulose, that's when we can think about adding another medication called rifaximin. There is more and more recommendations to start these non-selective beta blockers, carvedilol, nadolol, or propanolol for patients with even at early stages of their liver disease to help minimize the risk of progression. But if patients have these esophageal viruses that were detected, it's a medication that, or a group of medication that should be used more liberally. When to refer to us, all patients with cirrhosis, I think should be managed to someone with hepatology training for co-management. When should we consider liver transplantation? I mean, it's a big question, knowing that liver transplants, it's not necessarily possible in everyone, or that we don't have necessarily the organs for everyone with chronic liver disease. We have long waiting lists. So we have to be a little bit more selective as to when that should take place. But as a general rule, I would say that anyone who has developed this decompensated liver disease should be referred. Or if they have a disease that is decompensated, that despite the medical therapy, we're not able to control it very well. If we have a history of advanced liver cancer, or a liver cancer that we cannot treat because of the liver fragility, then that could become also an indication for as long as the burden of tumor is not so great. We use blood work parameters to calculate this MEL scores and these Child-Pugh scores. And anyone who scores more than that should possibly be assessed. Now, there are some patients, I would say, that probably are above this criteria who are actually doing quite well and don't need a liver transplant at all, but maybe at least have an opinion regarding the role. I think that people who practice as hepatologists on a regular basis will be very familiar with really the timing of referral. So just quickly over these little cases that I prepared, we have a case one, a 55-year-old. Sorry if I keep checking down. I'm on call for the transplant service and my pager keeps ringing. So I have the middle-aged patient who had steatosis on an ultrasound that was done for a completely different purpose. They don't have metabolic risk factors. They don't use alcohol. Their BMI is reasonable. They have actually excellent blood work. should we do any referral at this moment? If you look at this patient, you look that their FIB-4 is at 1.83. So if you follow what I said before, it's like, oh, he has a FIB-4 of more than 1.3, so maybe the patient should be referred. This is an example of how the FIB-4 has a limitation, that it loses its validity when you're actually doing in someone who has completely normal values. So in that case, it may not be the best test to assess. There may be others that are better, but at least you go through the process and let the hepatologist decide. I would say in this case that a referral is not needed, that because of the FIB-4 at this moment is not very good at really detecting it. But you know what? It could be done. Just give me 1 second, please. Hold on. Sorry, this is Dr. Marquez. I'm finishing a presentation. Is it really urgent, this call? Okay, thank you. Okay, I'm finishing a presentation. After 5 o'clock, I'll be available. Okay, thank you. Bye. I apologize for that. In this case number 2, I don't know what this lines, how they appear there. I'm not sure. But anyway, in this case number 2, a little bit of a similar case. Patient with obesity, type 2 diabetes, ultrasound was enlarged at 18 centimeters. We have all these blood test results. And now you do again the FIB-4 score and take a look, 0.75. And so like, this looks better than the previous case. And I would say, is referral needed? If you just think about the FIB-4 score, you will say, well, no. But in this case, this is where the subtleties start. Patient with a lot of risk factors, type 2 diabetes, obesity, and also on top of that, a liver that is enlarged on ultrasound. So this is a patient that, regardless of what the FIB-4 tell me, I want to be able to evaluate further to really assess whether or not he has or they have some form of advanced liver disease. They have a high ferritin. I put this question about the HFE, but I don't think it's relevant here. I would say that probably the patient does not have hemochromatosis due to ethnic background. Case number 3, regular alcohol use, BMI 27. They have some elevation of the liver enzymes as well. You calculate the FIB-4, 2.35, so higher than 1.3. Audit score is 12, so I did the audit questionnaire for alcohol use disorder. And so the question here would be, do we need to see this patient in hepatology and need for additional therapy? So my answer to that is yes, because of the higher FIB-4 score, I think that he should be having a further assessment for fibrosis. And based on his audit score, we would say that this patient is probably at this moment just at a medium risk or a medium level of alcohol use disorder. And maybe at the beginning, the patient just needs information and simple advice and not necessarily being referred or managed someone who has a problematic alcohol use disorder. And so to summarize, at the primary care level, I think that the mission is to identify the patients at risk, to use these non-invasive scores to screen for patients that could be at higher risk of fibrosis, or maybe all these other details like the enlarged liver, enlarged spleen, persistently elevated liver enzymes, and also be familiar with the pharmacological treatment that we have for MASH or for liver steatosis and alcohol-related liver disease. At our specialties level, we need this assessment of fibrosis that we can perform. We can identify the patients who have advanced chronic liver disease and do require closer monitoring and follow-up. We can identify the patients with decompensation, and we can prepare the patients for transplant referral. And this is what I have. And I think that we may have a few minutes for questions. I can take a few more minutes than just 5 o'clock if people are interested.
Yeah, thank you so much, Dr. Marquez. That was an amazing presentation. Thanks for sharing your knowledge on liver health and how to best care for patients. Obviously, it was a great presentation for healthcare providers, but also for patients who just want to be proactive with their liver health, make sure they're asking the right questions, and having effective conversations with their primary care providers. So that was great. We have a few questions in the chat here that I can maybe read to you just quickly before we go.
Yeah.
So the first one is, what are your thoughts on the current referral system for primary care providers to hepatologists for patients who are at risk for hepatocellular carcinoma? In your experience, are these referrals generally coming too late? What improvements would you suggest?
So obviously, I think that if we're talking about a referral system, it will be really based on which province we're talking about and health authority. The what I would say is that if someone needs ultrasound screening, so the screening for liver cancer, I think that anyone can actually prescribe that. If that is what is needed, primary care physician, internist, it doesn't really matter. Anyone can prescribe that ultrasound and that alpha fetoprotein level. That does not need to be done by the hepatologist itself. Now, when the ultrasound shows something that is suspicious, like a liver nodule that needs to be further assessed, then that's when I think that the referral to hepatology should come through. Now, I personally, I receive a lot of those referrals, and I think that we have a very low waiting time to see a patient who is referred with an abnormal imaging that could be suspicious for an HCC. But going back to the first part of the question, anyone could do the ultrasound screening and the alpha fetoprotein level. Sometimes I just keep patients under my care just to do that, because they don't have necessarily like a GP anymore that can do that for them. But if there is a healthcare professional, they can prescribe those ultrasounds and do the screening part.
Perfect, thank you. I have some patient questions here. My blood work is good, except platelets are 42. I have cirrhosis MASH, ascites, and varices, not bleeding in the esophagus and stomach. Would I be decompensated? Should I see a specialist if I have low platelets and enlarged spleen?
So it is probably the low platelet count and enlarged spleen. My assumption would be that it is because of the liver disease. Okay. If this person is not someone who is followed by a specialist or who has a contact with a specialist, either internal medicine, GI, hepatology, anyone with hepatology interest, I think that this person should be followed. Not that there's a lot necessarily that needs to be done at that moment, but I think that the monitoring is important, because it is the subtle changes that could occur over time, that if someone is still at an age range where transplantation could be offered, can start making us prepare ourselves for that possibility, or at least have that discussion with the patient.
Great. Another one is, in addition to raw fish, what about raw cheese, raw honey, and raw milk? And then the same person also asked vaccine must-haves for someone with liver disease.
So the question about like the raw honey and raw fish, there's nothing. Oh, sorry, the raw milk. There's nothing that has necessarily come up as a problem. And obviously, we're talking. We will prefer pasteurized milk. The use of unpasteurized milk in anyone who does not have it's potential risk to anyone, but it's not necessarily a greater risk to patients with liver disease. With respect to the vaccinations, I would say that the vaccinations that a patient should have are at least be vaccinated against hepatitis A, hepatitis B as well, if their disease is not from hepatitis B. I think the childhood vaccinations are probably sufficient. The ones that we think of more in adulthood, we would recommend pneumococcal vaccination as well. So, for example, something like Prevnar. Nowadays we are recommending more to consider as well the RSV vaccination, because it's something that is becoming a bit more of a problem in older age. It used to be RSV used to be something that we will just see in children, and now it's like, oh, we have older adults as well. And in addition to that, we still suggest the COVID vaccination and the influenza vaccination every year. Those are really the what I would say like the must-have. Everything else is probably optional.
Great. Do you have time for two more questions that are in the
I
chat?
do.
Okay,
Yeah.
great. Would the salmon tartar also cause infection, bacteria? I have cirrhosis and hepatitis autoimmune.
It could theoretically do it. It's anything that is like really raw fish could do it. And so there is that possibility as well. It is, I would say that it's more than just a theoretical risk. It is a risk that is real. And that's why we really recommend to avoid them, especially in people that have more advanced liver disease.
Great. And then the last question here, is there any way to find out what the cause of my liver disease is? What kind of testing is available?
So I would say like the majority of times, maybe over 90% of the time, we can have an idea of what, or a good idea of what the liver disease is after a panel of blood tests that we can perform. And elements of the patient's like history and also other medical conditions. If after all of that, we still have an unknown as to what is the cause of the liver disease, oftentimes we're going to recommend a liver biopsy then, okay? In a minority of cases, even after going through all of that, we don't have the cause of the liver disease identified, okay? There's a particular set of rare genetic diseases that are more cholestatic that exist, which nowadays we have access more to genetic panel testing to check, but those are really a very, very minority of cases. And yes, at the end of the day, there are a very small proportion of patients, very small, that after all investigations, we don't have a cause. We refer often to these cases as cryptogenic liver disease. Cryptogenic is a medical term for like, we have no idea. But cryptogenic liver disease will probably be monitored the same way that any other general liver disease will be, only that there will be no specific treatment or medication to change as, we can treat hepatitis C, hepatitis B, we can treat some autoimmune disorders. We won't have like a specific treatment for it.
Okay, and then just one last question, sorry. What about the heredity for fatty liver and current patient with elevated lab values?
What was the second part of the question?
The first part was heredity for fatty liver, and then the second part, current patient with elevated lab values.
Current patient with
elevated lab values.
So the fatty liver disease could be something that is familial, okay? It's not necessarily a one single gene condition where if you have two parents having it, then you have it, or if there's one parent, you will have it. Because it's what you need to imagine is that all these enzymes and genes that are involved in metabolic activity in the liver, there are many of them. There are over 30 of them, if not even more than that, okay? So it's more of a soup of enzymes that you have. And then you will inherit some from your mother, some from your father, and then that soup at the end may not be necessarily the same that they had. But because you share some of it, then of course there will be some potential risk of, if your parents had fatty liver and severe fatty liver, that you could have it as well. The And that's also what we look for when we ask, oh, in your family, was there any history of diabetes? Was there a history of cardiovascular disease? Was there a history of cholesterol problems? Because we want to try to see what sort of genes you may have inherited. Now, the second question is, if you have right now elevated liver enzymes that are persistent, the role at that time of your primary healthcare provider is to assess what is your risk profile, and then use maybe like some of these tests that I presented, like the FIB-4 score, which is quite popular, to try to then quantify what would be your risk of fibrosis. And if you fall into something that is more than just low risk, that's when having a second assessment, but this time at the specialist level, could be worthwhile.
Great. I think that's all the questions so far. I want to thank you again for joining us this evening. Your knowledge and the information you shared today was valuable and appreciated by everyone here today. I know you're busy, so you don't have to stay when I'm wrapping up the event, but just thank you again.
Thank you, and I do hope that the presentation was found to be valuable. I acknowledge that maybe some of the slides may have been a little bit full. Initially, targeting more healthcare practitioners, and maybe for patients a little bit more difficult sometimes to understand. But I also feel that I'm with a very keen and already educated crowd as well. So probably the concepts were actually not necessarily that unclear.
Yeah, it seemed like everyone was very engaged and really enjoyed the event. So thank you again.
Thank you very much. Thanks all.
Thank you.
Yeah, bye-bye.
So just before we wrap up the event here, I wanted to put some final polls up just to get your feedback on the event and some knowledge gain as well. So I'm just going to launch these ones here. If you can just take a few minutes to answer these. Okay, great. Thank you for answering the polls. I'm going to end that here. I just wanted to say, to learn more about your liver health, you feel free to follow us on social media. We're always posting the most up-to-date information on liver health, resources, recipes on our Facebook and Instagram, and please feel free to visit our website as well. And if you have any more questions that you can think of, please feel free to reach out to us on our website. We are more than happy to answer your liver health questions. We have a great patient support team, so please feel free to reach out to us as well. And I wanted to thank you again for coming to the event this evening. I hope you guys have a safe and wonderful evening. Thank you so much, guys.